there the patient is doing this for themselves. So I, as a dentist, am not going in and doing those things. But very often when you have sleep apnea, you're going to have a drop in the blood oxygen in that SpO2, and when it drops to a certain level, it indicates there's a problem. And if that's the case, it isn't in all apnea people, but generally it is. Then that's another aid that patient can use to objectively measure it, rather than utilizing these home monitoring equipment, which really makes a diagnosis. Many dentists are using the home monitoring equipment right now, and I guess will continue to do so. But again, who knows how it's going to sort out with the Wild Wild West?
Sure.
Things are in a flux.
So if the person has this appliance and is with a competent professional to help them go through the process of adjusting it, how long does that adjustment phase typically take before they're comfortable with it and they're able to see if it's going to work or not?
Well, most often they're going to be comfortable with it after a week or two, because you're going to be able to get it to fit well when it comes back. But that's the fitting process.
Okay.
The titrating it, which would be one that moves the mandible in different positions, can take some time depending on the appliance. Some appliances require that the patient come back to the dental office to have them reposition it. Some appliances allow the patient to do that. So, but generally, I like to give my patients anywhere from I like 3 months time for most of my patients. I like them to be able to not only determine what's best for them on a typical night, but I want to know the good night and the bad night and really move through that process.
Okay.
So that's a pretty comfortable time.
So a three month is a good trial to see if that specific appliance is going to work or not. Would that be fair?
Yes, and when I say work, it's generally they're working. It's how well it's working, and you're relating to, is it going to effectively resolve the sleep apnea problem?
Yeah, you'll reach a plateau within 3 months, so it's not you shouldn't expect for additional improvement after the 3 month window.
Unless you're with other issues with the appliance and it's requiring more other factors to get to that, what we call that sweet spot.
Okay, but for most people, it'll be that 3 month window.
Absolutely.
And for the people that you're seeing, what percentage of people who come in are able to get relief after they've had an intervention with the appliance?
Well, remember, these people are filtered before they're sent to me. I have about a 90% success rate, which I believe would be higher, but some people have not continued treatment, and maybe for financial reasons, and they may come back, but some of them have been through trial procedures. They have a trial appliance that I've custom made for them, which often may stop the snoring completely. And so I'm losing some to that. I would say, in terms of people who are not able to affect an adequate change, I would say it's closer to about 5%. Now, remember again that these most severe cases are already in the CPAP and they're not coming in to see us.
Okay, so that segment of the population who does require CPAP or would be appropriately categorized as severe sleep apnea, you're not taking care of because the standards really require that they have that as an intervention. Is that true?
Well, that's true, but there's another factor that weighs in. The compliance for the CPAP is more of an issue.
Sure.
Patients often find it more difficult to work with and unwieldy. The more severe apnea patients are usually more highly motivated, but even in that situation, it's not always getting the job done. Now, there are cases where I've been able to work with an oral appliance and use it in conjunction with the CPAP to enable them to lower the pressure of the CPAP. Mm-hmm. But that's not common, but that comes up from time to time with all of us. But there are other people who just cannot tolerate it. And I had done a paper several years ago where we were looking at it, and we saw that I believe about 25 to 30% of the people who are tested with the CPAP after the sleep study walk out that night saying they can't handle it. So
Okay.
from that, they're losing about 25, or losing 25 to 30% of the people just at their first attempt to work with it. Over the next 3 to 5 years, the remaining people who are using it, you are getting a 20 to 25% drop off from them. Now, that's from that maybe from 6 or 8 or 9 years ago that this information is coming from, and they've improved CPAP. They're ongoingly improving CPAP as far as uh, uh, making it more user friendly. But you can see even from that there is a dropout rate, and there are people with severe apnea who can't tolerate it.
Sure. Well, it's interesting to note that the vast majority of people will get some benefit from this and improve pretty dramatically. Now, once one has an appliance, is this a lifelong commitment, or by wearing it, does that type of exercises that gradually retrains the jaw to this new position so that eventually you don't require it?
Wouldn't that be great?
Yeah, I don't know.
It would. It is, unfortunately, it is not.
Okay.
Appliance in, working, appliance out, not working. And so you're married to the appliance once you get it, and these appliances do have lifespans. There is wear and tear on these appliances. Certain certain factors can influence the wear and tear to some degree. They're considered, the medical profession has called it durable medical equipment, and I do have a beef about that because it's put it into into another box. But they're categorized because CPAP is durable medical equipment. And based on their standards of care, every X number of years, they will replace durable medical equipment. And some insurance companies, maybe 2 years, some 3 years, but they have a life expectancy factor associated with them.
Okay, it's interesting. So, the challenge, I guess, is that many of us have had less than optimal nutritional exposures that produce this pathology of a non-optimal space that's in our airway that causes this obstruction or leads to it. Certainly, that's independent of the weight. I mean, that's a separate issue, but many of us have that. So, are there any other modalities that address it at a foundational level, like cranial osteopathy or structural movements where they can mechanically, kind of somewhat like braces in a way, where you wear them for a while and then the body readjusts, adapts, and you have a new system, and you sort of reset the system to allow it to function at a higher level?
Good questions. And certain, absolutely, different things can influence these things. The time that they're able to have the major influence would be during growth and development of that child. And an adult to some degree, but mostly growth and development of that child. And these interventions are for sure going to be helpful. And what you're looking at is changing that whole structural relationship. And for sure, you would want that relationship to be craniosacrally attuned to the whole system, and you would want the area to be harmonious with ease of speaking, swallowing, and breathing, movement of the tongue. These would be goals, and if you can diagnose the potential for this early, because it's literally, you can see it in a child. If a child has a retruded jaw or any issue like that, that's an issue. ADD, by the way, is to me is really impaired oral function. It's nothing more than a lot of adrenaline kicking in constantly to manage the airway. And you'll find this. It's interesting to see that the incidence of ADD in children appears to be when there is a change in teeth. You have the full-size tooth coming in, but the jaws are not fully developed. So guess what? What's happening to the tongue? Is it a little more crowded?
Mm-hmm.
Where's it
Sure.
going to go? Is it going to set off the alarm?
It seems like it could.
You can see it. I know you can visualize it, can't you?
Mm-hmm.
It's amazing. And the poor kid is given a stimulant. It's just a stimulant doesn't have some of the effects of the adrenaline, but that kid can't. The kid has that on-edge feelings because the adrenaline kicks in. It's a booster dose to save the day, and then the child's feeling that on-edge feeling from that adrenaline in the system. Like when you look over the side of a cliff or things like that, that does it also because that creates a distraction that affects the balance in our mouth and that lets the tongue drop back. So it's just that adrenaline. So that poor ADD kid really is, from my perspective, has impaired oral function and likely has issues of apnea that have not been addressed. And if you can look at a child even at 2 years old or 3 years, even a year or 2 years old, you can begin to see the relationship of the jaws. And it's not too early to go to a really progressive orthodontist. And there are orthodontists or dentists who are doing orthodontics who are very progressive, and they can sometimes make a little mouthpiece that helps to influence the movement of the tongue and the movement of the mandible and development of the jaws, so that child develops into structures that are in harmony with ease of swallowing, speaking, and breathing, and that birthright we all are entitled to.
Sure.
So I would say early interceptive orthodontics by utilizing functional appliances. People who are aware of craniosacral is definitely the way to help prevent this.
So if a person commits to optimizing their lifestyle, a really great exercise program, elimination of sugars, processed foods, eating high quality, whole, organic, locally grown foods, will that optimized nutrition and exercise program facilitate any other variables or factors that may influence the ability to relieve the obstruction? Or in your experience, is it not an issue because you're not going to be able to change the anatomy?
Well, it will do it from the perspective of that adipose tissue, the fat.
Okay, but other than that, you're not going to. If the person's normal body weight has reasonable percentage of lean body mass, then you're not going to see a change from your experience.
From my experience, it's structural. However, if you look at it, and I know you can see this also, look at the situation where the body's constantly compensating throughout the day to manage the throat, to manage that airway, breathing, circulation, to keep it where it needs to be. If it constantly needs to go into sympathetic state to increase muscle tone, doesn't it need sugar? So isn't that creating a greater need for the body to want sugar? And isn't that going to make it more difficult for that individual to lose weight and to follow these things and not have these cravings if it's constantly occurring? And if you can change that, you see that the body that the body doesn't need to have that need as much. It's able to have that a different state. That's probably most likely why I see many patients where we've treated the sleep apnea effectively, and I'm trying to get them in to see me. I haven't had a call from them in a while, and I want to make sure the appliance is working okay and it's fitting right, and I want to look at the side effects and say, well, Dr. Strauss, I don't have sleep apnea anymore. I started exercising and I went on a diet, or I've been doing it and it's what began working. I've lost a lot of weight, and I'm better. Now it may or may not be. I suggest they still get a sleep study, because when I was at Capital University and I had to do my mini thesis for graduation, it was on a patient with sleep apnea who we thought had eliminated through going on a vegan diet and a good exercise program. And the patient was down to his high school weight, and he was really slim. He was doing the rebounding, and he went back to his ENT, and the ENT spoke with him and said, you don't have sleep apnea. The paper was already submitted, and after all that, I suggested he go in for a sleep study. When he went back to the sleep physician who did the sleep study gratis for me, he still did have apnea. So it can have a profound influence, but you want to check. And
but still functionally, it wasn't impairing his lifestyle, and he was leading a healthier life and felt symptom-free. So I mean, those are the barometers. I mean, it really doesn't matter in some ways what this diagnostic study shows. I mean, unless it's reflecting something that one can't consciously perceive that may cause some problems. But typically, it would manifest itself in some type of symptom in their waking hours, I would